Good evening, Dr. Lovelina.
Very good evening, sir. How are you, sir?
Thank you.
Sir,
Rajan,
good evening, sir.
Rajan, good evening.
Hi, Ganga, how are you?
I'm doing well, thank you. You're there. How should I not do? Hello, Farida. Good evening. How are you? Good morning to you. And you are, of course, you are muted. Hello, Beth. Good morning.
Good morning.
This is Ganga. Yeah.
And good evening to you all.
I know. Hello, Mansoor. How are you? Nice to have you with us. Sharifa, nice having you with us. Mr. Ramakrishna Rao, hello. Asha, finally come in, guy. Good seeing you. Good. So I think Lovelina should be ready to start.
Yes, sir. Absolutely. I'm ready.
We'll just wait for 3 more minutes to come in.
No problem, sir. We'll wait.
Good evening, Gangadharan sir.
Good evening. How are you, sir? Mr. Shah,
I'm fine, sir. I'm fine.
You're not seeing you. Show your face to us.
Yes.
Sir, Farida ma'am is having some problem in unmuting herself.
Don't worry. She will unmute.
Yeah. She has sent a message.
She's not able to unmute. Okay, Prabhakar, can you just see that she's unmuting? Prabhakar has no control.
Gangadharan sir.
I've given access to her, sir. I make her co-host.
Show your face to us. Farida, just at your end only. Farida, you have to do the muting. We cannot do anything. And don't worry. Calm down. You will get it.
Sir, Farida ma'am is having some problem in
Don't worry. She will get it. She will get it. She can restart it once again. Farida, I suggest discontinue, come back. Okay, Prabhakar, can you just see that she's unmuting?
No, I already made her co-host, sir. She can unmute herself.
Farida, just at your end only. Farida, you have to do the muting. We cannot do anything. And don't worry. Calm down. You will get it.
Farida ma'am is having some problem in
Don't worry. She will get it. She will get it. She can restart it once again.
வீடியோ போடுறாங்க பெட்ஷீட் போத்தி
Once Farida comes, we'll start.
She has come, sir. She has joined and I've given co-host status to her.
Now I'm good.
Okay, wonderful. So can we, Farida, are you ready? Can we start?
Yes, we can start.
Wonderful. So Beth is also there. We can start. So good evening to all of you, and good morning to all of you in USA, and good afternoon to some people from Europe. So I think this is the first time we are having this kind of too much of mixture. So good evening. As I told you, welcome to all of you. I think this is the 4th day of our webinar, international webinar on social work professional and geriatric care, focusing on current roles, challenges, and emerging trends. Distinguished speakers of today: Dr. Beth Sippel, Dr. Farida Kasim Ijaz, both from Benjamin Ross Institute on Aging, which is in the history books of aging in the USA, way back 100 years ago. Both from Cleveland, USA, my dear friend, Dr. Irudaya Rajan, founder chairman, International Institute, Migration and Development, Trivandrum, India. and dear Dr. Asha Banu, professor at the Center for Health and Mental Health School of Social Work, Tata Institute of Social Sciences. Dr. Chanavir, professor and head of the Department of Social Work, Central University of Karnataka. And my good friend, Dr. Lavlina Littleflower, head of the Department of Social Work, Bharatiya University, who is going to chair this day's session. Beloved partners in our efforts to host the 6-day webinars, other than Dr. Lavlina and Dr. Chanavir, Dr. Mangaleshwaran from Bharati Dasan University, Tiruchirappalli, Dr. Lakshmi from Central University of Kerala, Dr. Paneer Sigamani from Central University of Tamil Nadu, Dr. Nalini from Pondicherry University, Dr. Chandramouli from University of Mysore, and Dr. Leena Ashok from the Manipal Academy for Higher Education, and respected Dr. Raja Samuel, Principal, Madras School of Social Work. I think it's a big list of partners in this group. And the purpose has been to, reach out to social work profession as many as possible. We are also very proud to share with you, we have participation coming from 26 countries. And the attendance so far has been in the range of 300 plus, first day 400, second day onward 300. For the first time we are hosting this evening, and for the first time we are hosting this program in the evening, we are trying to see what is going to be the outcome of, the number of participants. But nevertheless, I don't think I want to really give a big introduction to people living longer and the implications and the roles played by the governments and the United Nations, WHO, and a variety of NGOs who are involved, international NGOs and national NGOs involved in aging. I think one of the biggest focus our areas have been on social work role in geriatric care. I think our friend Dr. Rajan is here. He will talk a lot about, I hope he is able to touch upon this point. If he is not touching, at least I can get him to touch upon the migration of younger generation in pursuit of career opportunities, which has definitely left behind their parents. And, the parents are at a loss, particularly in a state that he lives, Kerala. And I'm sure it's happening across the country and many countries as well. I think we have been talking about care of the elderly and the role of senior citizens, a role of the social workers in respect of elderly care. And we are definitely going to look at the roles the social workers play in improving the quality of life of the elderly, vis-a-vis their role in families, neighbors, with the doctor professionals as nurses and other personnel in the what is called the multidisciplinary approach care, home health care, and institutions for homes have the options to take care of them. One small segment of people in the world who are forced to go to the institutions because of a variety of reasons. I think social workers play a dominant role in this. I think in the last 10 to 15 years of time in India, we have been witnessing growth of home care. And India is also witnessing a lot of private healthcare providers coming in a big way, though it's growing a little sluggishly. But I'm sure in the long run, with the number that's going up, the care of elderly will also be concentrated on the private care. And I'm sure Mr. Dalal, who's here, who's established what is called Association for Senior Living in India 10 years ago, is also participating in this program. We are also happy to receive him on this. And so I think we have, today is going to be probably focusing more seems to be on academics and research, because we have two people, Beth Sippel, who's talking about, care that she's rendering for almost, personally involved in the care of the elderly through services. We are all delighted to, listen to the speakers around here. And we have enough time available for us to deliberate on these important discussions. Yes, we have found that we are not able to address all the questions that people have been posing, but nevertheless, we'll try our best to do, whatever justice we can do. Now, we are also very proud that Heritage Foundation is very proud to host this global seminar. This is the second one this year, first one having been on elder abuse and the second one on social work. Now, I think we have a lot of takeaway already in the last 3 days program with more than 10 countries talking. I think today we have one more country, US, talking about it today. And we are really very, very proud to host it. So I welcome all of you. It's also my responsibility to introduce to you Dr. Lovelina. Dr. Lovelina is, basically a social work person. She is heading the, social work department of Bharatiya University, one of the leading universities in Tamil Nadu. She has, obtained her PhD in social work as early as 2002 from the Bharatidasan University at Bishop Eber College, Trichy. I think we have conducted a lot of programs with our university as Heritage Foundation, particularly promoting, intergenerational relations. We have also used, our good officers to train people, nurses, qualified nurses in the government public health centers and the government hospital. I think she has been with us in, a lot of such programs that we have organized in our city. So it's my proud privilege to welcome her also to this program. Before I close this session, I want to definitely tell a couple of things to people who are attending this program. Please ensure that you are muted always. We do not want you to, under any circumstances, unmute unless we request you to do that. 2, I've definitely got a request to all those people who are participating for the 3rd, 4th day and others who have not come in. Please acknowledge by reacting at the bottom of the screen when the speakers talk something relevant and you find them useful. Acknowledge it by at least, clapping your hands or showing your hands or showing some, some kind of feature. So that will give motivation to other speakers to talk, because speakers in a virtual form also need some kind of acknowledgement about the fact that they're talking something relevant. And 2, the next one is chat box, use of chat box. Please use the chat box to talk about today's program. And we don't want you to talk anything other than that. We don't want any of your personal, messages going in here, because that's not meant for chat box today. We want you to question. Even if you're not able to answer all these questions, you will be in a position to get back to the speakers and get some possible responses if they are able to find time to respond to it. And we don't have a today, all the speakers are speaking English, so we don't have any translator. Feedback. Please ensure that feedback form, which is being left to you after all the speakers have completed the talk, will be made available to you on the chat box. Kindly fill it up. Those of you who are not able to fill up today, for some reason, let me tell you, it will be extremely difficult for us to give certificates unless you fill it up for all the 6 days. If you are not able to get the certificate, you're not able to open the chat box now, please, Prabhakar, who's handling this from our office in India, will ensure that he will send you again and again, if necessary, a request for it immediately, because tomorrow it cannot be filled up. It can be filled up only today. It expires at midnight, 0000 hours. And any of you want some of you ask for PowerPoint presentations. We would be very happy to share with it, but please write to us after the end of 6 days program. We do not want our attention being drawn into anything else. With this, I welcome Beth and all of you, Beth, Farida, Rajan, all of you to talk this evening, and wish you all the best. Enjoy your sessions. I would love to enjoy listening to all of you. Thanks then. Dr. Lovelina, you can take over. Thank you.
Thank you, sir, and erudite guests and participants from across the globe. Good evening to all of you. Good afternoon and good morning. Before proceeding with the program, let me thank Dr. K.R. Gangadharan for having invited me to be a part of this wonderful international webinar on social work profession in geriatric care, current roles, challenges, and emerging trends. And Dr. Gangadharan sir has already given general guidelines for the speakers and participants. Let me also reiterate the same. For the participants, my humble request to all of you is that kindly mute your microphones. And when you want to share your comments, clarify your doubts or any deliberations, kindly use the chat box for posing all your questions or queries or whatever it is, so that at the end of the program, we can request the speakers to reply to your questions. And kindly mention the name of the speakers to whom your questions are addressed. And for the speakers, once again, my humble submission to you all is that kindly adhere to the time limit, because I think Dr. Gangadharan would have given you instructions regarding that. Each of you can have 15 minutes for your presentation. I request all of you to remain present for the entire program to take the questions from the participants. When there are too many questions for the speakers, I think with the permission of Dr. Gangadharan sir, that the speakers can type the answers, because if there are too many questions in the chat box, you can answer then and there also in the chat box itself, because I do not know, after all your presentation, we will have enough time to answer all the queries from the participants. So that facility could also be enhanced, and so that others could raise up with many questions or comments. So with that, I think we have now reached the most important part of today's event, the keynote sessions by distinguished academicians and practitioners from different corners of the world who are awaiting to enlighten us with their knowledge and experience in the field of gerontology. So without further delay, I would like to introduce the first speaker of today's program, Dr. Farida Qasim Ijaz, Senior Research Scientist at the Center for Research and Education at the Benjamin Rose Institute on Aging. She has over 30 years of experience in applied aging research. She is the recipient of the 2021 Researcher of the Year Award by Ohio Association for Gerontology and Education. Now I invite her and hand over the session to Dr. Ijaz.
Dr. Farida, are you okay with it, or you want Beth to take first, right?
Sure. Beth, do you want to go first? Do you want to share your screen and go first, Beth, or do you want me to go?
I can go first. I don't have
Yes.
the PowerPoint to share. I don't have.
So, Dr. Lavlina, can you ask?
Yeah, sir, no problem. Yeah,
kindly
no problem.
Introduce her. Kindly introduce
Yeah.
her.
I'm very happy to introduce Dr. Beth Sippel, an independent social worker licensed by the state of Ohio, who has served as the Director of Clinical Services for the Elder Care Services Institute of the Benjamin Rose Institute of Aging for the past 14 years. She has over 25 years of rich experience working with the caregivers, older adults as hospital, nursing home, and home health social worker. She also serves as a chairperson of the International Review Board of the Margaret Blankner Research Center at the Benjamin Rose Institute. Over to you, Dr. Sippel, please.
Beth, do you want me to share the screen?
Better, ma'am.
Yes, if you're able to, I would appreciate it.
Okay, let me try here.
Okay.
Can you see it?
Yes, Farida.
Okay, I can move forward if you want me to do that too. Just let me know.
I will. Thank you very much. And good evening, good day, and good morning to you all. Thank you, Dr. Gangadharan, for the invitation to be a part of the panel discussion. And my colleague and I, Dr. Farida Ijaz, work at the Benjamin Rose Institute on Aging in Cleveland, Ohio. On next screen, please. Thank you. And I'll be discussing the structure, the operations of our agency, what social workers do at Benjamin Rose Institute on Aging, and our response to the pandemic. Benjamin Rose was founded in 1908 by Benjamin Rose, a gentleman who was an entrepreneur in the Cleveland area. And we are a nonprofit Cleveland-based agency. Our mission is to support older adults and their caregivers and empower all people to age well through client advocacy, consumer responsive services, and applied research. We reach more than 10,000 older adults and caregivers annually in their homes, community locations, and by telephone and email. Our work is accomplished by addressing evolving needs in a changing society, developing and delivering innovative solutions, and promoting effective public policies through advocacy. Next slide, please. And here are programs and subsidiaries and areas of Benjamin Rose Institute on Aging. We all operate together to fulfill our mission. I'm going to begin at the bottom of the slide there with the Margaret Wagner House Apartments. We have apartments and we have 60 units for older adults with different requirements. The older adults need to be 62 years old. And we are located in the Cleveland area. Next is the Empowering and Strengthening Ohio's People, and we refer to this program as ESOP. And this program helps those who are older adults in the Cleveland area with financial counseling and helps them when they have difficulties with their own ownership, whether it be a foreclosure situation where they're in danger of losing their home, and advocating for them and helping them to obtain maybe some loans. Our next area of our institute is the Rose Centers for Aging Well. And we have 7 senior centers where older adults enjoy activities, educational programming, and congregate meals. We also, under this area, operate a home delivered meals program to those senior older adults who are homebound and cannot leave their homes. And then finally, we have the home and community-based services called elder care services. And this is the area of the Institute where I work. And in this area, we have in-person and telephone-based wellness services. And we also operate a senior companion volunteer program where senior volunteers socialize with seniors homebound to help decrease isolation. And so I'm going to focus on discussing the intake and assessment process for elder care services. And we have a centralized intake, which means when somebody calls in for help, either for themselves or a senior, we have an intake coordinator, and our intake coordinator talks with the caller to determine if Benjamin Rose is able to help the person. If so, we gather the necessary information and inform the program or the department manager of the older adult's needs. And if the senior needs mental health services, we send that information to the manager of behavioral health services, and that's the program for which we help people with mental health issues. And then she assigns a social worker to that case. The social worker then has 2 working days to call the potential client and arrange for an in-home assessment visit. We do the visit, and before the pandemic, we did the visit in the older adult's home. Now we have done the assessment visit over the telephone. Currently, we provide both in-home or over the phone. The choice is really determined by the older adult. And we offer that assessment within 5 working days. What else do social workers do at Benjamin Rose? Well, some of us are managers, and some of us, like my colleague, Dr. Ijez, work in research. And some of us supervise other social work managers and social workers doing direct work with clients. We also have social workers in the Rose Centers for Aging Well, and we have social workers who assess the client to determine if he or she needs a home delivered meal. We also have a social worker who works in our Margaret Wagner apartments, and that social worker helps residents who live there to get help in their own home, referrals to community services and advocacy. We are unique because we have social workers who teach and train other social workers in our agency about our client electronic medical record, and also a database that we call BenRose 360 that's used to track referrals to all our programs and departments. And that's our internal process. And we had a social worker very instrumental in the design and now helping to train all of us to use that. A social worker manages and works with our senior volunteers. We have a social workers in the Behavioral Health Services Department who provide counseling, case management, and group therapy. So you can see social workers provide direct client care and also manage our activities at Benjamin Rose and provide research. We have a lot of us who are working in different areas, but we all work to promote the client and caregivers' needs. Now I will discuss our response to the COVID-19 pandemic. In March of 2020, our reaction was organized, and with our CEO, Mr. Orion Bell, leading our efforts to pivot and provide help in different ways to our clients. So we had to suspend our in-person senior volunteer services. They began to call their clients and socialize over the phone. We also had to stop directly going to our clients' homes for counseling and case management. And the group therapy clients were unable to come into our location to receive group therapy. So those services were also delivered over the phone. Our senior centers were closed to the community, seniors, and the staff in the senior centers telephoned those adults, and they were offered a home delivered meal because some of those seniors were receiving a congregate meal at the senior center. Our financial counselors provided assistance over the phone. Our apartments were limited in visitors to essential others who were coming in to provide maybe personal care to those seniors. And the social worker in our apartments provided wellness checks to those residents over the phone. And so she did not go in at that time when the virus was very highly contagious in our area. Our home delivered meals program grew, and we ensured our drivers who delivered the meals had masks, hand sanitizers, and delivered the meals safely. So we had training for those folks on how to do that. And in our agency, we began to use Microsoft Teams to conduct our regular meetings and stay connected with our staff. And most of us worked remotely from home using laptops. Now we provide a hybrid model using telephone and face-to-face services as we manage this ever-changing environment. So thank you for allowing me to present today. I wish you well, and please stay safe, everyone.
Thank you, Dr. Beth, for your excellent presentation. And it was very lucid in the way that you have explained what are all the services you are offering in Benjamin Ross Institute on Aging, and also the roles played by the different social workers. In a sense, social workers in different roles, case managers, database manager, and then they have been involved in the case management, training, volunteering, counseling, and everything, whatnot. So you have mentioned all these roles played by the social workers. Thank you for the elaborate presentation. Now I invite Dr. Farida to just present her presentation. Thank you very much. Over to you, Dr. Farida. Yeah.
Thank you. I'm bringing up my screen. Can you see my screen?
Not yet, ma'am.
Don't worry, it will
Not
come.
yet.
Don't worry, it will come. Just.
Okay. I can always try again.
So I've connected it. Once again, connect. So Prabhakar, do you want to do that?
I can do it. Hold on.
Yeah,
Let me
Prabhakar
check
will do
my
that. Don't
phone.
worry. Prabhakar
I
will
can
do
do
it.
it.
Is it coming?
Don't worry.
What about now? Is it?
Yes,
Are you
yes.
able to see it?
Yeah,
Absolutely.
now we can see it.
Okay. All right. Good morning from our end of the world. It's morning. Thank you, Beth. Beth and I are both social workers, but we wear different roles and hats at Benjamin Rose. So even though I am a licensed independent social worker, as you can see, this LISW licensed, as well as a supervisor, I am basically, my title is a senior research scientist. So even though as a social worker, I'm not in clinical practice, but I'm on the research side, where what we do is to develop evidence-based social work programs and implement them in the field. So we do the research setting, research testing, and if they work in the field, then it becomes evidence-based or evidence-informed practice. And those practices are implemented in different parts of Benjamin Rose or across the country. So I will talk about a few of my elder abuse, elder maltreatment research projects. We have a lot going on at Benjamin Rose. I encourage you to go to our website, and you will have the link at the end of the PowerPoint, and you will see not just the types of services that Beth talked about, but the various research projects. We have more than 19 research projects. And in 15 minutes, I cannot talk about 19 projects. So I have decided to talk about just a few of the projects that I have been doing over the past decade, but this is not all the projects that I manage. So I will talk about some of the interventions that we developed on elder abuse. And these, we had collaborators in a virtual world. We work not only in Ohio, but in other parts of the United States. So our one big project is in Texas, where we are working with Adult Protective Services, which is the government agency that investigates cases of adult abuse, not child abuse. So this is adult abuse. We also work with a large healthcare system in Texas, as well as their charitable foundation as a partner. And we had other social workers, as well as the Federal Elder Justice Coalition, to help support our work. So we had two major projects in Texas where we are collaborating. One was a prevention grant from 2012 to 2016, and another grant 2016 to 2021, which is still ongoing, on just focusing on self-neglect. And before I get into what is self-neglect, I'll come to that later. So who were we trying to help as social work researchers? Who were we trying to help? In our Texas project, they were older patients of primary care clinics. In the second grant, we added the adult disabled population, 18 to 59. And most of these people were low-income Hispanic populations, and some of them were immigrants, first-generation immigrants like me, to the United States. Some spoke good English and some did not speak English, and their primary language was still Spanish. So our social workers, when we hired them to work on the grant, some of them were bilingual, spoke English and Spanish. And we were trying to prevent elder abuse, and we were training healthcare staff to identify the abuse, and we were trying for social workers to implement some innovative practices. So here in our first grant, we took 2 adult protective service specialists who work in that government agency that just investigates cases of abuse. We took them from that government agency, developed a contract and placed them in the healthcare system. It was a large healthcare system that operates all across Texas. And for those of you who are not aware, Texas physically is about the size of India. So that's how large of a state it is. And the 2 protective workers, they trained over 800 healthcare staff on how to screen for abuse, how to understand elder abuse, and how to report it to Adult Protective Services. What was also done was a screening tool called the Elder Abuse Screening Index, the EASY, was incorporated into the electronic medical record, So as soon as a patient came into the primary care clinic, the first person to check your temperature, to check how you're doing and collect your basic vital signs, also ask them 6 questions from the easy tool, whether they were safe at home or they were being harmed in any way. And based on this project and the screening, 23 patients were reported to APS, which we thought was not such a large number. It was over a 30-month period. Only 23 were reported to APS, but 92 scored like in the gray area, yellow area. We didn't know which way they were okay or not okay. So they were reported to the social workers in the hospital, in the primary care setting, in the WellMed medical management system. What we found was that all those 92 who were reported to the social workers, nobody got reported to adult protective services. So the social workers were doing something miraculous. They were putting in interventions that was preventing the abuse from happening. And they were linking those clients, the patients, to services in the community to help them and support them. And nobody was reported to abuse for adult protective services. So that intrigued us, that what are they doing? What are social workers doing that's unique? And another case, because there were 2 of the adult protective service workers were embedded in the system, in the healthcare system, lots of physicians, nurses, and other social workers, healthcare staff started calling them and saying, you know, I have this patient. I'm suspecting something is going on. They have these bruises. Doesn't look like they fell down. We don't understand what's going on. Or someone would say, this person has come into the clinic for a visit. Person is smelling. It seems like they haven't taken a shower for days. Is it self-neglect? Do you think they're self-neglecting, or a person who has depression or dementia? Something is going on that we need to investigate. Can you consult with us? Can you call us or email us or come to our patient care coordination meeting where we discuss this patient case and guide us if it is a referral to adult protective services? So as a result of those case consultations, you can see what happened. 529 cases were reported to APS. And those 529 patients had a total of 902 allegations of adult maltreatment. The majority were self-neglecting themselves, which means they were not taking care of themselves, not coming for doctor's appointments, missing those appointments. They had excuses when you called them to see what was going on. They were coming smelling. They were dressed inappropriately. If it was summer, they were wearing winter clothes. So there were majority, 90% of the 529 had an allegation of self-neglect. Other types of allegations included neglect by others, emotional abuse, exploitation, and physical abuse less, sexual abuse almost nothing. And half of the 529 were reported for the very first time. There were new cases to APS. So we think that this is where our prevention was coming in. If you take 2 experts in elder abuse, place them in a healthcare system, something miraculous happens in the sense that you're trying to prevent abuse from happening even further because you're getting elder abuse experts involved early on. So this sort of a planning led us to go to the next. This is a publication that we did on this topic at the American Geriatric Society. I encourage you to read our research. It's a descriptive project. In the next project with Texas, the same partners, we said we need to focus on self-neglect. Why are over 90% self-neglecting themselves? What is going on? So we trained social workers at the healthcare system to become experts in self-neglect. So that was something very unique. And we pulled records from the electronic medical records to look at risk factors for self-neglect, things like dementia, depression, you can't function, so you're limited in your activities of daily living. You have substance abuse problems, alcoholism, a prior report to APS, Adult Protective Services, prior report to a social worker. And we said we are going to develop a randomized clinical trial. So this was one of the few randomized clinical trials focused on self-neglect in the United States. We began that, and it was all social workers that were driving this project. So let's skip this and go into what was usual care in the randomized clinical trial. We had a randomly selected intervention group of patients and a randomly selected, and actually we started with randomly selected clinics, primary care clinics. Their patients became intervention groups. Another group of randomly selected primary care clinics became the control sample. And in the control sample, you still had usual care, which means a clinician was already trained in 2012 on how to identify abuse, how to use the easy screening tool, and how to report to APS, how to call the APS specialist and say what's going on with the case. So all of that. In an ideal world, I want to do the study where we don't have a control group that's so contaminated or biased with all of these already in place. It should be a clean samples where people get services of an adult protective service worker and social work intervention. The control group just gets healthcare. So the social workers began with a home assessment to identify self-neglect, to look at if the person has other needs. We used another screening tool called the Recognizing Abuse tool, which we felt was most sensitive because in the first study, only 23 patients were reported to APS based on a screening tool. So we said we want a better tool. We want a different tool. And this is a tool developed by the Benjamin Rose Institute. If you want to use it and translate it into another language, into Hindi or Tamil, get in touch with another social worker who is responsible for that. But right now she's on maternity leave till the middle of September. Screening summary, there's a screening summary also attached to that tool. And what did we do? We developed interventions to help people in the intervention group. Did the patient accept? Many people said, no, please, we don't want anything. Leave us alone. Thank you. Thank you, but no thank you. So we had to accept that. Humble pie, eat humble pie. Somebody's going to refuse you. Then was the issue resolved? The social worker would have to say if they accepted the service, did it get resolved? And is the patient still using the services at the end of the study? And we did 285 home visits, 192 control group, and right now the data are being analyzed. The report is due 2021, but next year, please look for publications from us. We've already started analyzing the data. So that's one study. And here are some of the services that people were referred to. Food assistance was #1. These were low income people living in so don't think that only in India there's a food shortage. There's a shortage that people need food. Food assistance was #1. Help with bathing, dressing, grooming, someone to come to the house, clean them up, clean the house. That was #2. People were very socially isolated. There was home modifications, mental health issues, healthcare. These are the kinds of services. Transportation, they were not coming to the doctor's office because they had no way of getting there. So the healthcare system began giving them vouchers and a van to come for their treatment, to come for their visit. So these are some of the kinds of things that we did. I had a case study, but I don't have the time to go into that. because I know I'm going to take too much time if I get into it, but it's a case where we helped a client. This is just one example of what social workers did. And client outcomes were very positive. For our work in Texas, we were nationally recognized, and we won the 2018 National Association of Adult Protective Services Collaboration Award. You can see me here. I feel like I'm 3 foot nothing compared to the director of Adult Protective Services in Texas, who's 6 foot plus. So for almost 5 feet here and 6.5 feet here, this is our team of social workers that worked on that project. And I'm running out of time, so all I'm going to say is that we have another grant that we are working now in the state of Oklahoma. And again, it's a social work project where we are replicating what we did in Texas and adapting it. For this time, not with healthcare clients, but with clients who are reported to Adult Protective Services for self-neglect. So that study is still going on till 2022. We also have developed educational programs on elder abuse. I will briefly say a little bit about this. We are in the process of developing 3 modules. This is based on a history of doing education and training on elder maltreatment for about 20 years now. But currently we are doing it so that we are developing a program, an online platform that we hope can be used anywhere in the world. So module 1, what is abuse, the types of abuse, how do you recognizing? Module 2, how do you screen? What are some of the tools that are good, including the recognizing abuse tool? Module 3 is the only one focused in the United States on Ohio laws. And I have a paper coming up with a team of colleagues in a book developed by Springer on this topic on education and training and on about elder maltreatment. The references are there. You can take a look at it. Anyway, I'm going to skip this. This is about the recognizing abuse tool. If you wanted to use it, you could contact this address, like I said, but she's on maternity leave till the middle of September. Here are some of the questions from the recognizing abuse tool. I don't have time to get into it. There are examples of there are only 6 questions, but then there are examples of what is, say, one type of abuse, physical abuse. There are signs. So there is different ways of looking at it. And I'm going to stop here just because I'm running out of time, but I do have a list of my publications, just a few of them on adult maltreatment. And this is the book that I talked about that is being done in India on Handbook on Aging, Health and Public Policy, Springer. So that's the one that's in press. And these are some of the publications. Thank you so much. And I give the screen back to somebody else. Thank you.
Thank you, Dr. Farida. It was indeed an intense and very interesting presentation. And in the crux, you have explained about a social worker researcher, how a social worker can take up research projects and how they can work as a good researcher. And especially the way you have given the inputs on adult protective services and the various tools you have developed, and also the explanation about self-neglect and all your publications. Everything has kindled interest among the participants, and I hope you will get many mails from the participants today that you will be actually disturbed, that it is quite interesting. Thank you so much. And now it's my pleasure to invite Dr. Geriatric sir, former professor at the Center for Development Studies, Kerala. He is at present the chair of the NOMAD, Global Knowledge Partnership on Migration and Development. He is the founder, editor-in-chief, Migration and Development, Taylor and Francis. He has also authored many books on elderly care and aging in India and abuse and neglect of the elderly in India. I invite sir to share his valuable insights. Thank you, sir. Now over to you, sir. Dr. Geriatric sir.
Thank you. Thank you. I hope all of you can hear me well. And
yes, sir.
Yeah. Thank you so much for Gangadharan for asking me to be part of this very interesting discussion which is going on. And also, thanks for Laulina to basically to introduce me so that so that I'm going to speak sometime. I have no PowerPoint because I thought that I don't want to, people can see me rather than looking at the power and numbers, because I always talk about numbers. Today I thought, as long as we have seen 2 PowerPoints, both by Farida but I have seen I enjoyed Farida's presentation because I know that. And I am glad to be part of this. And anyway, as told by Ganga, probably I'll take 15 minutes to speak. Now, because I see a lot of course, we have, as Ganga said, there are many people attending from many countries, but I would like to focus mostly on what is currently missing in the aging research and where the future researchers should get into the future. I think that is what I'm going to spend some time on that. Now, many of us always believe aging is some type of, people don't happy with aging. I talk to many people. I think it is one of the important thing is that aging to be celebrated. I think this is something we have to discuss more on that. Aging to be celebrated. I think this should be the talk of the whole day. How to celebrate when you get old. I think we don't do that. Now the second, being a demographer, aging is created by all of us. It is not suddenly one day you find morning, you see a society is old. No, it is created by the society, and then if any society is a old society, that is also indicates that society is highly developed. Take the example. In 1900 in India, probably 100 years back, none of us are born. 1900, none of us are born because you should be 120 years right now. India had more death rates than birth rates. In 1911-21 census indicate India had a negative population growth rate. Today, Indian people are talking about population policy in some states. Some states they are talking about population policy. India is talking about a 2-child family, and China is talking about 3-child family. So if you look at it historically, 1900 on an average, Indian was living only 25 years. And very heavy mortality, crisis periods, influenza, fever. So 1900 to 1950, all the people throughout the world were spending how to control mortality. This is what we were all doing. Every country, today we are talking about COVID vaccination. There were vaccination was stopped in 1900s about malaria. There was vaccinations. So what all we did, we made people to live longer. But we are not celebrating that now. How many people did experiment to do a lot of medicine to make people live longer? We have reduced maternal mortality. We have reduced child mortality. We have done so much things. And that led to the growth of elderly. And what we did, because the people were started living longer in 1950s in India, for example, all the countries in the world from 1950 to 2000 were talking about how to control fertility. For example, my grandmother had 9 children. I don't think any grandmother in the world now, after a few years, you will not see anybody had 9 children. And my mother was 9th. If you are talking about the UP, say Uttar Pradesh in India, talk about 2-child family, probably my mother would not be born and I would not be born. But then India is the first country in the world to talk about population in the first 5-year plan. So 1950 to 2000, what we did, every country wanted to reduce fertility. China started with the 1-child family in 1979. Now they are telling, relax, have 1 more baby. But people are not relaxing anyway to have 1 more baby. You can tell them 2-child family, they're not going to take, you can tell them, but nothing is going to change. So what you did, you have reduced mortality, you have reduced fertility. What is the consequence? Consequence is very simply reflected in the age pyramid of any country. Today, throughout the world, people live longer. It is created by the policy. It is a success of the medical professionals. And then every country reduces fertility. Everybody has only 1 child. In fact, in Kerala, where I live now, out of 10 couples, 1 couples are infertile. Infertility is almost 10%. So people are not able to have even 1 child. And we are talking about not very long, 60 years back, they had 9 children in this country. So we created the aging society. We created, and we never talk about that. And this is a success. We created, we devoted 100 years to reduce mortality so that people live longer and reduce fertility. You should have quality of children. Today, you walk around any place, I don't think any couples have more than 2 children. And now the fashion in India is only 1 child. This is a new fashion. People want to have 1 child. All things had led to what is called the aging phenomena. So the aging phenomena to be celebrated because I live longer than my father. You should feel you live longer than your mother, your grandmother, your great-grandmother, great-grandparents. Or you celebrate as an individual when you get old. First, you should celebrate it. Then your family should celebrate it. Then the society should celebrate it. Your community should celebrate it. Everybody should celebrate. Then only the research will go because we are not celebrating. Everybody looking very sad. Oh my God. I have my 2 grandfathers. Yeah, I know someday when you go to some house, I have my 2 grandfathers with me. Oh my God. And especially COVID time, everybody want to pass their old parents to another brother. But unfortunately, there is no another brother. You have only 1 child. And you are taking care of. So it is you created, and now you blame the old people. They live longer. It is what you told them. Otherwise, people will die of heart attack. Now you have bypass surgery, angiogram, all these things to be able to live longer. Your father, your grandfather. Now you say, oh my God, aging is a big problem. I will say that itself, the concept is wrong. Aging is an asset. Aging is an asset. If I have a grandfather, it is an asset to me. Did I realize that? No. I think that is where we have to mainstream elderly into society, into development. And then second point I would like to mention is that today everybody put elderly in 1 basket. I think this is very, very bad. India has 140 million people. All of them are same? No. No. You have young old, you have old, you have oldest old. You talk about 140 million, create 1 aging policy. You are putting in 1 basket. All of them are unproductive. All of them are unhealthy. Not all. 60% of the MPs in the current parliament are old people. The parliament in India today, 60% of them are above 60. So we have to realize that the elderly we are creating, we should celebrate it. I think this is something, we should not talk about elderly as 1 group. They are different groups, subgroup. For example, 1960s, I was looking at this literacy rate among elderly was only 10% in India. Future elderly will literate, highly working, highly competitive, highly healthy. You should imagine them in the future. 30 years from now, what will be the elderly population? We are not talking about that. And for example, even the definition of elderly, we never talk about that definition. Do you define elderly as 65 plus? Why should you define? In America or in India, we say 60 plus is old person. No, when I was born in 1956, elderly was defined at 60 plus. Today I am 60 plus, still you are defining the same age, 60 plus. And then you say population is increasing, it will increase. Suppose you define every year, you like you get increment in your job. Every year you increase the age. This year 60 plus will be called old, next year 61 plus, 62 plus, 63 plus. If you go on doing that, then what happens? Aging will not increase. You are doing technically you are making wrong. For example, in 1956, when Kerala became an independent state in India, 1956, Kerala was formed. That time, the retirement age in Kerala was 55. And an average Malayali used to live only 55 years. In 2022, an average Malayali lives 75 years. But the retirement age is only 55 still. It is not changing. Then you say old people, they are getting pension, they are not dying. Now you are worried why people are not dying. In 1950s, we worried how to make people to live longer. Now you are thinking differently why people are living. Can we have euthanasia bill? Can you have mercy killing? Or can you do something to get rid of these old fellows? I think this is something we are doing wrong because we have achieved Now we are killing that particular thing. So what we have to do? We were adding years. I think we should give them quality of life. I think this is something we should look at it. The third point I would like to make is COVID-19. COVID-19. Please remember, I was so happy with COVID-19 in one sense. We got first wave is over, second wave is over, and Kerala is leading the third wave now. And I would like probably we may go to even the fourth wave. But please remember, COVID is non-discriminatory. COVID, it is not discriminating anybody. It has gone to the American Vice President's house. It has gone to the superstar of India. Amitabh Bachchan had COVID-19. Our Home Minister had COVID-19. It is not bothered about who is he. Rich, poor, old, young, everything. But what you did through your policy, 65 plus should not go out. You have discriminated against the old people. Sit at home. Don't go out. And there is a special provision. 65 plus should not go out. Why? They have done some sin or what? They have done a crime that says should not go out. Everybody goes out. Why they are discriminatory? They think you will get. You have comorbid, all those things. And what you made them? Ask them to sit at home. And most of them almost become mental health, depression. And one lady was crying to me. I used to go and cry in temple. Now the temple is closed. Where you will go and cry? These elderly people, they want to cry. They go to temple, they go to church, everything is closed. And what one lady was telling me last week when we were doing a survey, prior to COVID, my son will leave at 7:30. My daughter-in-law will leave at 8 o'clock. 8:30 house is empty. I am in charge for the house 8:30 to 3:30 until my first granddaughter comes. Now COVID came. They said we are all working at home. Husband is my son is working at home. My daughter-in-law is working at home. My grandchildren is working at home. They told me you should not go. They put me in one room and they give me food like untouchable. It is inside. They all go out. I am inside the house. Now the freedom which I had before the COVID, now they are all working at home. And I am not able to move out of my room. They said COVID, COVID, COVID. This lady asked this man, his son, did you see COVID? He said, I have not seen. You have not seen COVID. Why you are telling it is in our house? Nobody has seen COVID till now. And I was telling to somebody in a seminar on migration, COVID has no passport. COVID has no visa. It travels throughout the world. But I was not allowed to travel. I have a passport, I have visa. You are worried about something which you are not seeing, but you are seeing me physically, but you are making me immobile. And we have discriminative policies towards elderly during COVID-19. I think this is something very, very important what we did. And that led to mental health and what Farida talked about, elderly abuse, financial abuse, because everybody is at home. This elderly used to have some space for them during the things. And another thing which is very important for the place where I live, which Ganga rightly said, this society is more migratory populations. There are many houses we go in Kerala, elderly will be living alone. And children used to come once in a year. Now they also use the opportunity. COVID, we are not coming from America. No flights. So people are using COVID-19 an opportunity not to visit their grandchildren and parents. Yes, it's a good opportunity for everybody. Like the laborers are exploited. They were on the road. We have seen in India, internal migrants. Everybody using COVID as an opportunity to punish those people. COVID, we are using COVID as an opportunity to harass some people, like migrants we have done in India. The migrants and international migrants, they were stranded in Dubai airports. You know, like one fine morning within 4 hours, he said, don't move. And their life is on mobility. Children are not able to come. Today, children sitting in America is seeing their grandparents' death through online. They will say the dead body is now leaving the house. It is moving towards the church. The prayer goes on. We are talking about a new life. And then came what is called the digital India. Everything is digital. These elderly are not digitally literate. I talk to many people, they don't know how to use, because I am not able to use. I want your food. My son does. My daughter does. I am very illiterate in the computer. I may speak, but computer-wise, you can order food, you can order many things we don't know. So we are stuck. The elderly who are 60 plus, 70 plus, 80 plus, living alone, living with their wives who are also old people, they are being completely discriminated during COVID-19. We never talk about that. And what we did, when the lockdown announced in India was, COVID was only 500. Last March 28. Today we are trying to overtake America. We are number 2. We hope we will not overtake America anyway, but things were that we may overtake. And what did you do? You cannot stop the COVID. It is spreading everywhere, but you made the old people to suffer more compared to anybody. Locked at home. I saw one old man buying bread. He said, I am 75. My wife is 70. We have nobody. They say, don't come out. Where will buy food? That's why I told the Kerala government, please visit them. You are putting a sticker in the house where there is a COVID. Please put a sticker where there is a old person. They also need equal support like your COVID patient. COVID patient is always followed up. They are always tracked. I told you, track these fellows, old people. They are alone. Some of them are alone. I think this is something we should look at it. I think finally, what we should do, we have achieved. Now everybody is living longer. But we should ask the question, if the elderly are enjoying the long life which they received compared to their parents, I say no. There are elderly suicides coming up in a big way post-COVID. We are not talking about elderly suicide because mental health is only one aspect. They are committing suicide. I saw one man who is 91 committed suicide in Kerala. I was thinking he would have lived only 2 more years. 2 more years. What happened to him? Mental health issues. Living together, less number of children to take care. His wife died. You know, you lose when you grow old. You are losing your spouse. You are losing your own children. You lose your friends because you cannot gain. When you grow old, you are losing people. Gaining will be very much less. You will have only grandchildren, but your spouse, your brother, your sister, your uncle, that your age group, you are every day you are losing. You are losing. But then adding new friends, you cannot go in the college and stand outside and look for the college students. I want to make your friendship. People will laugh at us, old people. What, this man is coming here? But you are doing 30 years back in the college. So when you grow old, you lose friends, and then you need a lot of support system. Is the community is giving to you? Is your family is giving to you? No. I think what we have to do, we have to integrate migrants into development. Once you do that, you believe that they are assets. Yes, as economists, we always believe. If you think the elderly are assets, so now what happened? We think elderly as liabilities, like your bank balance sheet. One side asset, one side liability. I think elderly are assets, they are not liabilities. I want to conclude with a small, recently happened. There was a man coming in everybody's house to buy old things. He said, if you give anything old in your house, please give it to us and we'll give you money. Then one grandchild who was 10-year-old running to that man. Sir, I have something old in my house. He said, what do you have? It might be around 80 kg. Would you like to take? He said, what is the 80 kg you have old? My grandmother. Can you take and give us some money? I'll stop here. Thank you very much.
So thank you, sir. That is indeed an excellent presentation. As usual, in your own style of extempo, you have given various perspectives regarding the difficulties faced by the elderly and different aspects which are quite new, though we are experiencing or though we are witnessing all these difficulties in our day-to-day life. Still, when you put it in words, that was amazing to understand the problems, especially aging to be celebrated. So that was indeed a wonderful statement that you have given, and all other aspects, reduced mortality, reduced morbidity, which has increased the longevity of the elderly and all that, and also the problems related to migrant population, especially elderly people living alone in their own places, and the COVID, after effect of the COVID, and how the family, though they are all in the under the one roof, but all are aloof. So that you have put it in an excellent way. So, and though you are very humorously explaining the problems, we could understand the anguish and also the compassion towards the fellow elderly people. We could understand that, sir. Thank you so much for the presentation. Now I invite Dr. Asha Banu Salati, professor of the Center for Health and Mental Health, School of Social Work, Tata Institute of Social Sciences, the pioneer of social work education in India. Her research projects and field managements have evolved and strengthened social interventions for marginalized communities. She was awarded the Linnaeus Palme Fellowship to visit and teach at the Gothenburg University, Sweden in the year 2012. And now I'm very happy to invite her to address this gathering. Thank you, ma'am. Now over to you. Dr. Asha, ma'am, please.
Yeah. Thank you. Good morning, good afternoon, and good evening to all the participants on the Zoom screen. Indeed, it was a very emotional presentation by Dr. Geriatric. He has thrown so many challenges that's before us in the Indian context. And also I'm speaking after 3 brilliant presentations, so a little hesitant here, but I would put my thoughts that I've captured in 10 slides. So as the earlier speakers from the US spoke, social work has its own unique way of looking at macro to micro and micro to macro. So we always adopt a systems approach, and always in the Indian context or elsewhere, we always want the students to feed back to intervention. We always keep saying that our students' research should always have implications for social work practice. And again, as social workers, we always look forward to knowledge creation in unique areas. That way, I wanted to say that social workers have worked and built knowledge around different new arenas like green social work. Now, even in Tata Institute of Social Sciences, we have a new stream called Disability Studies in Action. It's a new stream in the field of social work, and the program is being run for the past 7 or 8 years. And we also have Dalit and Tribal Studies in Action. These are new streams that are evolving because social workers are evolving knowledge through research. And the other USP is praxis, that is a synthesis of theory feeding back to practice, and mutually theory and practice feeding back to each other. And for all of this, we also use data, and we are in a unique position to fight for social justice and working on social action and advocacy. So these are broadly certain areas that social work research can contribute to. While I was doing this, I also found this particular framework, 4 types of social work research for knowledge building. This is again from an Ohio State web link, wherein they keep talking about translational science overview. When Dr. Farida was talking about her work in the field of elder abuse, it almost fit very well within this framework. So I'm not even going to give any other example which I had in mind, but the way she spoke about epidemiology, protective factors, theory testing, those becomes part of the basic research. And how these basic research had fed back into intervention research, which again she beautifully explained. What are some of the interventions? What are some of the interventions that worked around elder abuse and self-neglect? And then from there, how it moves towards implementation science, where we look in terms of cost effectiveness, cost benefit analysis, dissemination science, adoption of evidence supported interventions, and implementation fidelity. While the example is being given by the speaker, that's Dr. Farida, here I'm putting this frame. This is how the research moves. And the 4th dimension is how we work in terms of strengthening the research in itself. Through every research, how are we going to tweak the methodology? How are we going to be effective in our participant recruitment? How are we going to adhere to protocols, data analysis, etc.? So this is one slide I found very interesting, and it's very important to look where we stand. I actually did a very simple exercise. It's not accurate, but again, it is a kind of estimate. What I did is, with the help of our librarian, who is very efficient, have looked at over the last 6 years, what are the number of dissertations the social work students have produced in the field of aging. Okay, in a university where every year there are 60 to 70 PhD scholars who are submitting thesis. Every year there are near about 200 MPhil scholars who submit their thesis. And every year there are 750 MA students who are submitting their thesis. So it becomes like 6 into 750 and 6 into 150. And for PhD, every year, if you look at 6 into 50, that's 300 theses. But you can see the number of theses done in the Social Work Institute. So it's basically, if you look at the pink, it is only 3. The maximum PhD thesis in the field of aging is 3 in a given particular year. Otherwise, in 2020, so far, no one has submitted in the field of aging. When you look at 2019, we have again 2 theses that have been submitted. And again, when we're looking into the thematic, these are some of the themes that the students or the scholars, the PhD scholars have worked. That's disaster, gender, livelihood. The proportions, the percentages are given there. Elder abuse 10.7, mental health and disability, health and nutrition, institutional care, living conditions, living alone, all these concerns. And very few studies focused on active aging. And again, the similar number of theses have been done on women and aging. So this is a compilation from the D space. We used a filter and looked at how students have engaged from the social work discipline. And you can see proportionately, the number of theses submitted in the field of aging is very negligent in number. So with the same curiosity, I looked at the repository Shodh Ganga, where all the PhD scholars can upload their thesis. So that is also a repository of information of PhD thesis and sometimes published, unpublished work located within that particular space. When I looked at that, again, I mean, it's like for pan India, but when you look at the number of PhD theses that are loaded in Shodh Ganga is maximum 5. And that also was in the year 2016, 17, 18. Otherwise, in certain years, we can see 0. In 2015, not even a single thesis was done in the field of aging. So when I looked at this, I was contemplating as an academician and also as a research guide who have guided scholars in the field of aging. So where do we stand? Researching on older population is not becoming a priority, or it's not really the buzz issue or something that can gain fame for the younger adults. So that's one I found, because the numbers are very negligent. And even if the students are engaging, what is the kind of methodology and rigor and how it is translated into policy, into practice? That's also something I wanted to look at. Then applicability and translating them into practice, how far we have succeeded with this existing. And also mostly located within one paradigm. That's the framework I showed, where people are, or the scholars or the researchers are looking at only profiling or exploring concerns, problems of vulnerable groups, trying to understand causal pathways, all these quantitative, descriptive, exploratory studies, or in terms of creating narratives and stories of elderly who are vulnerable. And that also hit a chord when Professor Geriatric spoke. It has to be celebrated. But again, when we are looking at the thesis and the knowledge so far we have created, we are almost creating a very problem narrative and a vulnerability scenario. The other thing I understood is context specific. Often the theses that are done are borrowing perspectives from diverse contexts and may not always be applicable to our Indian context. Like whatever Professor Farida mentioned, a kind of well-evolved system. There is a macro, there is a meso level support system, there is a micro level system. And articulating abuse, if I have to give a simple example, now when all the facilities are there and the family is supported to take care of the elderly, and how abuse is defined in a particular context. But in the Indian context, when the families themselves are going through transition, minus the support of the state, how abuse should be deconstructed in an Indian context is always I would want, because we leave out macro. Because in the Western world developed context, always there is a macro that's functional, very vigilant, very active, policies, protocols. All the medical practitioners are equipped in identifying elder abuse. But in an Indian context, minus the macro, when we are locating only elder abuse in an Indian context, that's very problematic. So we have to evolve methodology to capture all the three systems and see how each of the levels has to go through transition, and not only looking at what's going on in a micro context. So context specific studies are also important. We should not be partly borrowing perspectives from diverse contexts, but take the perspectives and adapt it to an Indian context. So these are certain observations that I went through the different, through the browsing through of abstracts. Now, for me, the way forward is drawing from several perspectives and focusing on priority research areas to build knowledge and strengthen practice skills. Now, when we are looking at practice skills, again, where are the settings? In the institute, we had diploma in gerontology. All the students who are enrolling into the program will always ask for where do we go and work, or where do we place them for field work? Very limited organizations and very, very limited organizations with limited perspective, and where do they go for placement? So it's very important, not only in terms of priority research areas, but also have to create avenues for practice models, because again in TISS, we always do this extension projects where we demonstrate field-based models. Right now, we have ample models in the country, but how are we going to look at that, and how academia is going to engage with these practice models, be it Kshetra, be it heritage, be it silver innings, be it different models in the Indian context? How do we look at them, and how do we work mutually collaborating with them is very important. So there are diverse perspectives. Looking at life course and critical gerontology, I have not seen a single study that uses critical gerontology as an informing perspective. Looking at social ecology and intersectionality, and how we look at certain priority research areas in the Indian context, looking and capturing diversity, looking at equity, looking at changing family structure, drastic change in the family structures, and how it's going to have implications on elder care. We have not thought about that. And the same way, the notions of elder care in the Indian context is so different. And how are we going to capture that as well? How are we going to minimize stigma, taboo around these issues? Then ageism. Ageism is again under discussed. All the isms that we talk in the Indian context, we do not discuss adequately on ageism. And abuse, again, very much, it's like it's there. There are research studies, but again, have we really done context specific studies to understand what are the several risk factors and protective factors, and also the increasing crime against the elderly? And as Professor Geriatric mentioned, that the number of increasing elder suicides in the country, and the mental health concerns, there are several priority research areas. But again, as I put the title of the first slide, where do we stand in all of these issues? So with all of these perspectives and like focusing on contributing into the priority research areas, how do we build knowledge and evolve practice skills? With so much of a complexity here, it's very important to evolve a discipline. Maybe that would be my end remark to Dr. Gangadharan, because he's the one person who relentlessly fights for this cause and conducts a lot of seminars and workshops and international conferences to take the lead and spearhead to bring this discipline in the Indian context, where it is being offered as a specialization in itself. So with that, I would also say to focus and invest. Coming back to the research, it's very important to strengthen the research agenda on aging. It should be a collective effort. Now, when I'm looking at the participant list, there are several organizations working on the elderly. What is going on? What are they contributing? Do they have adequate resources to hire professional services, professionalized social worker? what's happening in terms of training and capacity building of these organizations. Like in Ma'am Farida's presentation, it was very clear. Protocol, online modules, training of existing organizations. How do we work like that? It should be a collective effort where academia and practitioners have to truly come together and work. Okay, these are the practice models and how the academia can work with the organization and strengthen the model, or do intervention-based studies or implementation science and look at how we replicate models in different places. Emphasis on intervention research and implementation science. There are innovative models and there are several enterprises for the age, but then only when we visit them, we try to understand. When we visit them, we appreciate that model. But again, are they adequately captured? And whether the efficacy has been captured, whether the replicability and upscaling has been done. That's one other point. And now when we're looking at intervention research and implementation science and looking at evidence-based models, creating protocols, etc., I'm also looking at, as social workers, we are also equipped to look at participatory action research. We can always look at locally relevant solutions, because when we're working in a tribal context, how you work with the elderly and co-create interventions, and that also is an important aspect where intervention and action becomes hand in hand, and also it has an emancipatory effect on the target group that we are working with. So participatory action research is also something we can emphasize. And considering that there is lack of interest among young adults or young researchers, it's very important to promote researchers or encourage researchers through research fellowships and grants. Because I've always seen, there are several organizations like Smile Foundation and others will always give a fellowship of 10,000 for students to take and work on a particular issue. And in terms of Indian context, maybe the organizations who have adequate funding can look at critical issues and announce that any PhD scholar taking up this research would be given a grant of, or would be given a fellowship. That would definitely prompt young scholars to take up issues around aging. Then there are several faculty members who are getting large-scale grants, and it's very important to engage scholars in the large-scale grants on aging. That way, we are also creating a cadre of young adults to look at, because it should not always be young adults versus older adults. It should be how all together working in terms of promoting intergenerational justice. There are several points I've had to talk about, but then I think I would take it up as a Q&A. The conclusion is, in the Indian context, there's a tremendous scope. And again, as the previous speaker mentioned, there are a number of people who are sitting in the parliament or otherwise. There are several concerns. People are definitely struggling. There is ageism related issues. There is early retirement. There are people in the informal labor sector. And there are children who are migrating. In the tribal project I work with, there are certain phases of the year, like 4 months, the younger children, women will completely migrate, and only the senior citizens will be left on their own to take care of themselves. There are several problems, and definitely there is a tremendous scope for gerontological social work or social work in geriatric care to evolve as a standalone discipline. And it's very important to use this webinar as a platform, because there are several countries who spoke here, and we also saw the differences in terms of intervention, what's happening where there is a well-evolved mechanism, and where there are no programs on geriatric care or gerontological social work, how we are struggling and how the efforts are sporadic and getting scattered, and it's not giving the impetus for any kind of radical change in the Indian context. So the existing policies and programs need to be updated to meet the diverse needs, and to do all of this, building research agenda to feed back to interventions as well as policy making. So this is my last slide. And I also wanted to say to Professor Geriatric, the celebrations were there in the past. I have heard certain communities do celebrate the 1,000th moon. I also have seen Sashthyapta Purti where they are celebrating 60th birthday. But unfortunately, there is this right duty matrix. Whatever is due for children, children take. And somewhere the practices that celebrated aging is diminishing and vanishing. Maybe we have to get back to those older practices that have been celebrating old age and aging, and maybe, old wine or a new wine in a old bottle, or old wine in a new bottle. We have to reinvent. And I also agree that we have to celebrate aging, and we have to shift the gear and shift the perspective to look at the strengths of the older population, what they can contribute, and not look at them as a liability. While concluding, I also want to say this: there are internalized stereotypes. I can't even express to my mother certain aspects because there is an internalized stereotype. What she wants, she will not do, because immediately she will talk about what the others will say. Right from dressing to eating, there is definitely internalized stereotype. And with that internalized stereotype, there was a proposition to work in the ashrams of Vrindavan. We were thinking of how to really bring in active aging, how to promote livelihood options within that space for the women. But that proposal did not materialize because people felt older women should be singing budgets. So always there is a notion on aging, there is energy, there is buzzing energy, there is wisdom, there is so much the older population have to contribute, and tweaking our methodologies, creating more participatory approaches, shifting gears in terms of looking at with what perspective we want to look at the elderly, we have to do. And again, I conclude by saying there is heterogeneity, there is strengths on one side we have to capture, and also there are vulnerable populations. We have to be mindful of the vulnerable populations, and our research or policy program interventions should cater to this entire range of groups within the heterogeneous older adults. With this, I conclude. Thank you.
Ma'am, thank you so much. It was indeed an excellent presentation, ma'am. As an academician, you have given an overall picture about the issues relating to the gerontol or the geriatric care or gerontological social work. First, you have started with the importance of research in social work, how we have to bring out the praxis, that the synthesis of bringing out the practice into the theories into practice, that you have given out with a very beautiful explanation. And then the importance of the different types of research, and then the negligent areas where our students, especially in the universities, how they are doing research in the geriatric area, that is elderly care. There is a missing negligent percentage, only the students are taking up research, and especially the methodology also, they are not very well versed in getting into the research. And once again, the problem of applicability and translating them into practice, all that you have very beautifully explained, and the problems, how it has to be sorted out in terms of how it has to be overcome. The challenges that also you have explained in the way forward. I thank you so much for giving us various inputs, especially for the young researchers in social work, how they have to take it up. The various issues you have mentioned, whether it is theory with practice, or the methodology, or the research areas, or the challenges as elderly, how they are facing and how it has to be done. So thank you, madam. Thank you once again. And now we are proceeding with the next speaker. Our last speaker of today's program is Professor R.M. Chanavir, Professor in the Department of Social Work, Central University of Karnataka. He has successfully undertaken and completed projects funded by the UGC and Indian Council for Social Science Research. He has extensively published in journals of national and international repute and presented papers at various international conferences. Thank you for accepting our invitation, sir. Now I invite you to share your ideas and thoughts relating to the challenges of social worker working in the geriatric care. Sir, now it is over to you, sir. Please. Sir, your mic is muted. Kindly unmute.
Unmute. Please unmute. Please unmute your mic. Yeah.
So still your mic is not unmuted, sir. Kindly unmute it.
Abakar, can you just do it?
Yeah, sir is not able to.
Mr. Chanavir, can you just disconnect and come back? Better to come back, because we can't unmute it. You only have to unmute it.
So just exit, sir, and then again you join, sir.
Yeah. Am I audible, madam?
Yes, yes, yes.
Let me share.
No, you must be visible.
Yeah.
Is he visible? Yes, sir.
Yes,
He's
yes,
visible,
yes.
but
Yes,
his
sir.
screen has to be shared, sir.
I'm just sharing my screen.
Yeah, please, sir.
Yeah. Is this visible, please?
Yeah, you have started sharing the screen. Yes, sir. You make it as a fit into the screen, sir.
Yes, yes, yes. Thank you. Thank you. Thank you. Thank you. Yeah. So, good evening, Chairperson Madam, Dr. Gangadhar and fellow panelists and dear participants. We have had very wonderful presentations by our earlier speakers. When we look at the first slide, this man with a happy and smiling face never gives an impression that he was old, maybe around 80 years, but never gives that impression. He made the whole world laugh and he made people never feel he was old. That impression he could able to give. So let me go ahead that we understand that aging is the process of development, maintaining functioning ability for our well-being. I just give the demographic aspects. Already Uday Rajan sir has given it. The elderly population forms 8.6%, and it constitutes increasingly a big number. We classify into three categories: young, old, and very old. When we look at the Indian perspective, wherein we see some kind of changes in the perspective, the way we look towards aging or elderly persons in our society. It has more our cultural base, right from Vedic period. It was assumed by people that a human being live 100 years, 25 years is distributed into four, ashramas. So especially the last Vanaprastha and Sannyasa, it is related to elderly or aging. So we have been culturally trained or socialized to respect elders. Dignity, respect, and recognition always found important place in the value system of our culture. Even in Buddhism, it is construed as a continued growth to a more sophisticated way. Although suffering was the core, aspect of the philosophy. In later period also, up to British period, there was not much difference, but elderly were always respected in our Indian society. But after the advent of British rule, the scenario changed because of industrialization, modernization, modern values started taking part in our social and cultural life. Joint family, very fascinating institution that formed our Indian culture. And it is true that today, nuclear family, the structure of the family is a important feature of Indian families today. But still, joint families persist. Even though nuclear families are there, but elderly care is taken care of by the small families also. Or it is shared between the families related to the joint family. Indian society passed through different phases. And when we look at the post-industrial or post-modern society, where we look at the shift from binary society that was based on caste system or gender or different types of categories. So that went out, that
was totally changed due to the social transformation. 1 minute, yeah. So we come to the issues with regard to the problems of the elderly. So it can be health related problems, psychosocial related problems, financial problems are all studied through different research projects. Importantly, these problems persist because of the value system, change in value system, because of postmodernism or neoliberal economy. Intergenerational gaps are becoming more wider. The elders were respected earlier. The rewards they were getting, the dignity and the recognition that they were reaping earlier, such values are changing now because of the technological advancement also. Access to mobile, internet services, IT, exposure to IT enabled services and all, dependency on elders is reduced. As a result of that, there are gaps, spaces wherein we see the gaps between the younger generation and elder generations. So elderly abuse is a serious phenomenon we observe, and our social support system support is not that strong nowadays as it was earlier. We find different kinds of abuses to elders, whether it is physical, sexual, verbal, financial, economical, all these kinds of abuses we see it. The studies indicate that most of the abuse, elderly abuse, is very prominent. One is verbal abuse. Verbal abuse is related to the financial, property and other issues. These are very common as far as the elderly abuse is concerned. Most of the verbal abuse and other abuse is linked to son or sons than the daughters, because we have more stake in the property. Although it is women or daughters also have right, but even now sons or men have claim more right over the property or other assets issues. As far as elderly abuse is concerned, the scenario is different as far as the socio-demographic factors are concerned. The elderly who are educated, who are having, who had income or livelihood support, financial stability, they were not much vulnerable to the abuse, because they were aware, they knew how to handle the such situations. So the problem is with regard to the elderly persons who were lacking in education, income and livelihood support system. Other aspects are cognitive impairment. Although it is part of aging process, the quality of life comes down very drastically. And most important aspect is that the 1 minute, since power. Most important thing with regard to cognitive impairment is that most of the elderly persons suffer from mental behavioral disorders and also depression and other aspects related to mental health. As a result of that, the quality of life comes down. With regard to poverty, the national policy for senior citizens, it also indicates that 2/3 of the elderly in India, they live below poverty line. And the study also suggests that increasing poverty of the households with elderly above 75 plus, except Kerala and other states, this phenomenon is commonly observed in other states. However, saving behavior is commonly observed even in elderly persons, despite their poverty and other issues. But nowadays, we see that because of longevity, life expectancy has increased because of this reduced mortality or decline in fertility, increasing life expectancy, or access to health services and other factors are responsible for this phenomenon. There are also protective factors and security factors with regard to healthcare services and pension or income support or public assistance support to the elderly persons. As a result of that, we find that elderly persons are able to live. The issues are with regard to quality of life and other aspects. Another study, it also indicates that the higher ratio of elderly to the adults in the highest quintile, if we divide the elderly population into 5 quintals, 20 years, the percent. So the highest quintile, the elderly people have more, the households having low income. As the gender aspect is another thing which is very important when we look at the elderly. In all aspects, whether it is health or mental health issues, there we find differences in the based on gender. Whether it is life expectancy or mortality or survival to extreme age, there is gender difference. These studies also indicate that gender has a biomedical relevance, which is very important when we study elderly or aging. We need to have gender perspective because it's one of the significant factor observed in the studies. Studies also indicate that the gender-related medicine approach has to be evolved because most of the women live longer. It is also human longevity is also associated with gender and biological gender and other social psychological aspects. Biopsychosocial environmental aspects are very important. They play a very important role as far as elderly persons are concerned. Another phenomenon is with regard to the widowhood and elderly. Widowhood is very common in old age. It is also a very stressful life event as far as elderly is concerned. But studies also show that widowhood has mediating factors and moderating factors also in terms of education, income, labor participation, livelihood support, social support, lifestyle. These are all the mediating factors influence the quality of life of widows. So wherever we see the self-rated health and the association between these mediating factors with self-rated health or quality of life is very strong. Also, sometimes these factors influence as moderating factors on the quality of life and self-rated health. Important aspect here is that Indian policy on elderly or senior citizens has taken this aspect also into account. The policymakers also focus on the employment opportunities or livelihood opportunity that can be created, that can be facilitated for the elderly population. One more aspect that I would like to add is capital perspective, which is very important as far as elderly person is concerned. Of course, in our traditional families, the families, even in modern families, some families do have very strong positive value system for the elderly, place, dignity, respect for the elderly in their families, but still human capital is very important. Earlier, we knew, even in our childhood days, we looked to elders who used to teach us Ramayana, Mahabharata stories as moral lessons. The moral education, they were the moral educators in families. So moral values were very strong because they had cultural space as moral educators in each and every family. So we have to look towards elderly from human capital perspective, that they have wisdom, they have knowledge, they have experience, they have skills, they have abilities that we need to respect. They are not liability, but they are born. So another aspect with regard to capital, psychosocial capital is very important. We have been looking, our speakers mentioned about how we celebrate aging. So social capital is very important aspect as far as elderly person are concerned. Social capital also enriches the psychological capital of the elderly persons, their social connectedness, their social mixing up, are having trusted relationship with their fellow persons, fellow beings. That all gives them a very strong social support, happiness, and feel confidence to lead a happy life. Social capital is also understood as a very relieving factor. It also confirms, affirms, and facilitates the abilities of the elderly persons to deal and handle their day-to-day aspects with regard to maybe daily living skills or instrumental daily living activities as such. Social capital also focuses on improving the health and cognitive functioning. The strength of social capital is very important, even in maintaining both health and mental health issues of the elderly persons. Economic capital is very important, that elderly do need, some population, some part of the elderly population, they do have economic capital in terms of assets, financial, movable and immovable property, for which they may need support or guidance to consider their capital as either saving instruments or helping them to guiding them with financial guidance to improve their economic assets, which will help them to increase their economic support for leading a quality life. It is also very important that elderly, which forms 8.6% population, needs to be considered as a political capital class. So many senior citizens, they influenced the policy formulation of our senior citizens. They are many associations members are part of the system now, National Council of Senior Citizens and all. So they do have vote bank value that needs recognition, and then they have capacity to influence the policymakers, legislators, and other stakeholders, so that they gain bargaining and negotiating skills which they can use for their welfare and well-being. The acts and policies, they are the product of the political capital that the senior citizens and the associations working for the senior citizens played very important and instrumental role. Another dimension I would like to highlight on social entrepreneurship, the role and significance of social entrepreneurship, social innovation as far as geriatric care sector is considered. When we look at the post-COVID pandemic situation, we know that education is very badly affected, economic sector is very badly affected, production sector is very badly affected, employment sector is very badly affected, although agriculture sector is not much affected. Agriculture and other allied sector, that is one strength of our Indian economy, which protected the livelihood system. We need to look at elderly care or geriatric care sector from social entrepreneurship point of view. The gaps, the needs, the challenges, the problems that the elderly are facing can be converted into entrepreneurial opportunities or business opportunities to create skill development, opportunities for skill development, and entrepreneurial initiatives that can be taken up by young people or elderly people. So this is a very important sector where we need to shift from medical cost to social care cost or geriatric care or social care cost. because our system is still dominated by allopathy. Our system is still dominated by very dominance of medical professionals. Social care sector professionals do have important role. Social entrepreneurs do have, or social workers as social entrepreneurs do have very decisive role in ensuring creating self-employment or employment opportunities through different business initiatives or ventures. Geriatric social workers have very social workers have very important role, already emphasized by our earlier speakers in terms of clinical interventions or service interventions, advocacy, networking. I think social workers as social entrepreneurs can play a very decisive role, a model role that can create a new social capital in our system. We do have government initiatives to ensure rights, entitlements, social security program schemes. They are taking care of the basic needs or minimum needs of elderly people in rural, tribal areas, especially the elderly persons who are part of poor households. The public assistance program or social security schemes have very strongly influenced to maintain and sustain their life. Most important aspect in this is our policy programs, especially again we need to add the geriatric care initiatives. That's where our healthcare sector is not taking a lead role. It is limited to just medical approach. What I would like to highlight is that we can elderly people, we can ensure their dignity, rights, entitlements. There are gaps in our policy programs and legislation. The system is not that sensitive to respond to the problems, challenges, needs of the elderly. Whenever they find problems at the household level, they do experience despair or helplessness or hopelessness. System needs, whether it is law enforcement agencies like police system, legal machinery, civil society, and other stakeholders need sensitization. So, elderly friendly system needs to be part of the present society. So with this, I conclude my presentation. Thank you very much.
Sir, thank you so much, sir. And it was a scholarly presentation, as mentioned by Dr. Gurumurthy, that you have touched upon all the domains of the elderly and their care, especially the right from the Vedic period, how the elderly were respected till date, the modern India, how they are perceiving everything you have spoken and well explained, and also the concepts relating to the problems, their abuse, and how that has to be made as challenges and how to overcome those challenges also you have clearly explained in terms of social entrepreneurship, social capital, and public assistance, and also in the policy level, what are all the changes that could be made by the government. Everything you have explained, sir. Thank you so much for the excellent presentation, sir. Now I think with the permission of Dr. Gangadharan, sir, shall we take 2 or 3 questions more, sir, because I know there is a paucity of time, but still
just take 2 minutes, only 5 minutes left. So take 2 questions.
Yes, sir.
What I suggest, if you don't have a question, you can yourself ask them, because all the 6
sir, actually
comes in onto the screen also.
Yes,
so
sir.
also comes to the screen, 2-3 questions and maximum. Because I think you have to stick to the time. Thank you.
Yes, sir. Because many participants have given their appreciation to all the speakers, especially right from the first speaker till the last speaker. They have given their excellent appreciation to all of them. And only few questions they have raised, and I think I can ask those questions if you permit me. Only 2 questions I'll ask so that we can finish the program within time. So it is to Dr. Beth. I hope she's there still. Dr. Beth, I think someone has asked you, could you please explain what is the reason for so many cases of elderly deaths occurred in elder care institutions during COVID pandemic in US? So are you there, ma'am? Can you just take this question? Dr. Beth?
Yes, I'm here. Thank you. If I can clarify, it's the role of elderly deaths. Is that the question?
Yes, sir. I'll repeat once again the question. Could you please explain what is the reason for so many cases of elderly deaths occurred in elder care institutions during COVID pandemic in the US?
Oh, thank you.
Yeah, Lavalina, can you ask Chintamani to remove he can stop sharing the screen. Please ask him to stop sharing the screen.
We'll do that. Yeah. Dr. Chintamani, can you remove it? Can you remove your presentation?
Stop
Yeah,
sharing the
I'm
screen,
trying,
sir.
sir.
Yeah,
Please
yeah.
do that.
Stop
Please do
sharing.
that.
Yeah, yeah. Yes, sir. Yes, over to you, Dr. Beck. Yeah.
Yes. There are many reasons why older adults have occurred deaths
Is it clear?
during COVID.
Yes, sir.
Can you hear me? Okay.
Yeah, yeah. You can just proceed, Dr. Beth. You can proceed.
Okay. So there's many reasons. Some could be that some people had difficulty obtaining, if they're still working and they're older. Some people were not able to go out to their jobs, so that could be some reason. There could be a lot of different reasons for the deaths. With our agency, some people had problems paying their taxes. Some people had just many different reasons. We had financial counseling for older adults before the pandemic and during the pandemic as well. Before the pandemic, the reasons some people could not is some people, the amount of their Social Security varies by the different work they do here. And it could be that they didn't get enough Social Security every month to help pay for their debts, or that they had difficulties paying they had to make a choice between paying a rent or paying for the medication. That happened prior to COVID, and it still went on during COVID. So those are some of the reasons.
I understand. Thank you. Thank you for that.
Can I add something, please?
Yeah.
I think the question was not about so much about deaths, but about deaths in facilities, in nursing facilities or residential
I'm
care.
sorry.
That's okay. I can give a reason. And I think the reason was that the healthcare system in the United States became so overwhelmed that not just the staff were also falling ill, the families of the staff were falling ill, as well as the older adults, because they lived in close proximity to each other, and not everybody had a single room. So because they didn't have a single room, the spread of infection was very fast, and it became very contagious. And with so much illness, a lot of people started dying in nursing homes, and the system became overwhelmed. So I don't think it was necessarily a case of neglect by staff or neglect by the facility. The system had no experience in handling something like this. And that's why, because the elderly had a lot of comorbid conditions, they got the infection much more easily, and they were transmitted it more easily to others because they lived together in a congregate setting. Even though they were isolated, I think there was a lot of discussion of how older adults became isolated because they were then locked in their rooms.
And this is true. I have the personal experience of doing counseling in a nursing home. And so I go in now and went in during the pandemic. And when the pandemic started, the residents had to stay in their rooms. And then a lot of different nursing homes had different units. But when the pandemic first started, they were not testing for the virus in the nursing homes. And so that spread, as Dr. E just said, very quickly. And because they weren't testing the staff that was coming in to the nursing homes, then the staff was working even with the individual residents in their rooms. And that's how even more quickly it spread. And that was when we first started seeing signs of the virus, and we were not doing testing. So I also think the lack of testing and for the people coming in to the nursing homes contributed.
Yeah, thank you so much. And indeed, that was the second question to Dr. Farida relating to the deaths that happened in elderly care institution, whether you have come across any cases that has happened in elder care institutions. So that was the second question one of the participant has asked. Maybe you can answer that if you have an answer for that.
Just so I clarify, the question was there any cases of self-neglect?
Yeah, that happened in the elder care institutions itself.
So we didn't look at self-neglect in nursing homes or in residential care facilities because we felt if it was happening, it would be neglect by others, not neglect by self. So our studies on self-neglect in Texas and Oklahoma are focused on people who live in the community to see why are they self-neglecting? Is it depression? Is it because they live alone, because they don't have family supports? What they have dementia? What are the reasons? And then based on what the needs that were identified for each individual person, it was individualized care planning. They were linked to social supports and services in the community to help them to remain in the community. I couldn't give the example of my case study, but that was one example how we prevented it from becoming worse. So we didn't look at self-neglect in nursing homes or residential care facilities.
Yeah, thank you, Dr. Farida. I think with that, I close the session. Before that, my concluding remark is that today's webinar, I thank my wholehearted thanks to Dr. Gangadharan for the excellent presentation by the speakers. And as an academician, the take-home message today for me is that as an academician, how I am supposed to concentrate on the research in geriatric care or gerontological social work, number one. And the various facilities and interventions that is happening in the developed nations like US and other places that has been given very beautifully by the researcher and also the service provider in the Benjamin Rose Institute. So that was excellent. And also the reality, the practical problems or difficulties, what we have faced and how elderly or aging should be celebrated, the way Dr. Geriatric sir has explained. So that needs to be taken care, and also the various issues and also the possibilities of doing research, making it as a policy, and how it has to be implemented by Dr. Asha and also by Dr. Chanavir. All that are the important messages that as an academician I am taking home, and that will be practiced. So thank you so much for the opportunity, sir, and thank you once again for all the speakers. Excellent presentation. I'm looking forward to collaborate with all of you in the future, near future, and so that we can do something good for the society at large and in particular to the elderly. Thank you so much. Thank you once again.
Thank you.
Thank you, sir.
So I just want to say thanks to all of you. I don't want to take time because we are just stuck exactly 7:30 here. Thanks a lot, particularly Beth and Farida. I think all others are my Indian friends. I can always say thanks to them. But particularly Beth. Beth has been new to us. Farida has been with us in the earlier conference, and Beth new. And once in a way, we'll trouble you once or twice in a year. Beth, join us and give us the support that we need. Thanks a lot.
Thank you.
Thank you.
Thank you for inviting me.
Rajan, as usual.
Thank you, sir.
Asha, fabulous, excellent. Thank you so much.
Thank you.
Dr. Chanavir, thank you so much.
Thank you, sir. Thank you very much.
Thanks for doing it. Wonderful session of moderating it. Thanks once again. Take care. Thank you.
Thank you.
Thank you.
Bye-bye. Bye-bye. Thank you, Marina.
Well, thank you.
Thank you. Thank you. Thank you. Bye.